Imagine this: a sudden splitting headache, your heart pounding like a drum, and a cold sweat breaking out all over your body. You might think it's just stress, maybe a really bad anxiety attack, right? But what if these aren't just common everyday woes, but something? Wow, something far more specific and hidden deep inside you.
It's a really dramatic internal event,
hmm
a physiological roller coaster, definitely. And often it goes completely undiagnosed for, well, far too long.
Exactly. So today we're taking an in-depth look at a rare but incredibly impactful medical condition, a pheochromocytoma. Think of it as a tiny, sort of rogue adrenaline factory, usually nestled within your adrenal glands, that suddenly starts churning out massive, uncontrolled surges of stress hormones.
Yeah, and our mission today is really to peel back the layers of this fascinating, often missed condition. We'll explore what it is, how it throws the body into disarray, the surprising patterns it follows, and how medical experts, play detective to identify and manage it. This exploration hopefully offers you a shortcut to understanding this complex medical mystery. We'll be drawing from detailed medical notes and research to guide our journey.
Okay, so to really dig into this, where do we even begin with defining pheochromocytoma? It certainly sounds like a mouthful.
It is, yeah. But let's simplify it. A pheochromocytoma is basically a rare tumor that specifically pumps out massive amounts of stress hormones. It grows from specialized cells, chromaffin cells, primarily found in the adrenal medulla, that's the inner part of your adrenal glands, sitting right on top of your kidneys. About 90% of these tumors are found right there.
90%, okay.
But what's crucial to understand is that about 10% can actually pop up outside the adrenal glands. And these are known as paragangliomas.
Ah, okay. So it's a very particular kind of growth, constantly churning out specific hormones. What are these hormones exactly, and what do they do to the body when they're in overdrive like that?
Well, the tumor excessively secretes hormones like norepinephrine, epinephrine, and sometimes dopamine.
Mm.
Think of these as your body's fight or flight chemicals, but just way too much of them. Norepinephrine, that's the most common one, acts like a constrictor. It makes your blood vessels squeeze really tight, almost like pinching a hose. And that dramatically raises your blood pressure.
Right, the hypertension.
Exactly.
Yeah.
Then you have epinephrine, often associated more with adrenal tumors, which speeds up your heart. That causes the pounding sensation, the tachycardia. Dopamine is rarer, but its presence can sometimes hint that the tumor might be more aggressive, potentially malignant. So together, these excess hormones basically put your body into this constant high alert fight or flight state. It leads to severe high blood pressure and a whole cascade of what we call adrenergic symptoms. All those classic signs of being stressed or scared, but, dialed up to 11.
And what's particularly striking about this condition, I read, is that it has some unique, almost mathematical patterns to how it presents.
Yes, that's what's truly fascinating here. It's what we call the rule of tens. It's an epidemiological pattern that, well, doctors often use it as a memory aid for some key statistics about these tumors.
Okay, like what?
All right, so first, about 10% are extraadrenals, meaning they're paragangliomas forming outside the adrenal glands. Second, about 10% are bilateral, so they affect both adrenal glands. This is actually more common when genetics are involved. Third, around 10% are malignant. They can spread to other parts of the body. And importantly, we define malignancy by whether it spreads, not just how the cells look under a microscope.
Interesting distinction.
Yeah. Fourth, a significant 10% are familial, meaning they're linked to specific inherited genetic syndromes. And finally, about 10% are pediatric, occurring in children.
Wow, that's quite a set of coincidences.
Yeah.
So it's not always in one spot, and genetics can play a pretty significant role. What does that tell us about how tricky this condition might be for doctors to actually pinpoint?
Absolutely. I think what's truly insightful here is how these seemingly neat percentages really underscore the disease's cunning variability. It's not just a textbook case, right? It forces doctors to think beyond the obvious. It highlights why considering those extra adrenal locations or the possibility of a genetic link is so crucial for actually catching it. And that genetic link in particular is vital, not just for the patient, but potentially for their family members who might also be at risk.
Okay, so given all this internal chaos, what does it actually feel like to have one? I mean, you mentioned the initial scenario. I've heard there's a classic set of symptoms.
There is. There's a classic triad of clinical features that should immediately raise suspicion. First, severe throbbing headaches. Second, palpitations, meaning your heart is racing, pounding, or has an irregular beat. And third, profuse sweating, diaphoresis.
That sounds pretty intense.
It is. And what's interesting is that these symptoms can be episodic. They can come in sudden, intense attacks in about half of the cases. Or they can simply show up as sustained, stubborn, high blood pressure in the other half. Other common symptoms include intense anxiety, tremors, looking pale, that's due to the narrowed blood vessels. Also weight loss, because your metabolism is just in overdrive, and even something called orthostatic hypotension.
What's that?
That's a dizzying drop in blood pressure when you stand up. It often happens because your body is effectively running low on fluid volume due to the complex hormonal effects.
Wow, that sounds incredibly disruptive and frankly terrifying. What can make these symptoms suddenly spike or become worse? Can something trigger a crisis?
Yes, definitely. There are several known precipitants of crisis. These are situations or substances that can trigger a sudden, dangerous surge of these hormones. Common examples include things like anesthesia, any kind of surgery, or significant physical trauma. Certain medications can also trigger some antidepressants, pain medications like opioids, steroids, even the contrast dye used in some imaging scans.
So things people encounter relatively often in medical settings.
Exactly. And pregnancy, that's a unique one. It can also trigger crises.
Hmm.
And it's particularly challenging because its symptoms can unfortunately mimic preeclampsia. That makes a correct diagnosis incredibly difficult for expectant mothers.
Gosh. So if these symptoms can mimic so many other common conditions, like you said, anxiety or just high blood pressure, how do doctors accurately diagnose a pheochromocytoma? How do they play detective, to find this hidden enemy?
Right, the detective work. Well, the first crucial step is always biochemical testing. We need to look for those elevated stress hormones or their breakdown products in the body. The most sensitive test usually involves collecting urine over a full 24 hours. We measure something called fractionated metanephrines. If there's a really strong suspicion, sometimes a blood test for plasma-free metanephrines is a great initial choice. It can give a quicker answer. There are less specific tests too, like looking at general catecholamine levels or VMA, but those first two, the metanephrines, are really key.
Okay, that sounds like a solid starting point, but I imagine it's not always completely clear-cut. Could something else throw off these results?
Absolutely, and this is a critical point. It's vital to be aware of potential false positives. High stress levels from, well, anything really, certain medications like some antidepressants, TCAs, SNRIs, even conditions like obstructive sleep apnea or chronic kidney disease, all of these can interfere with the results and make it look like a pheochromocytoma when it isn't one.
Oh, wow.
Yeah, and this raises a really important question for doctors. Why is understanding these false positives so vital? Because without that careful consideration, a patient could potentially undergo unnecessary invasive procedures based on misleading test results. And that's a risk we always want to avoid.
That makes sense. So once those hormone levels do suggest it's likely a pheo, how do they actually locate the tumor in the body?
Right. Once we have that biochemical confirmation, the next step is imaging. Pinpointing the source. Doctors typically use advanced scans like a CT scan or an MRI of the adrenal glands. These help pinpoint the tumor's exact location. CT scans are very effective, highly sensitive. MRI is often preferred during pregnancy because it avoids radiation exposure.
Yeah.
Now, if the tumor is tricky to find, or if there's concern it might have spread metastasized, we use even more specialized scans. These are often called functional imaging. Examples include things like IMABG scintigraphy, which uses a tracer specific for these neuroendocrine tumor cells, or PTT scans, especially with tracers like ogadotatate, which can be even more sensitive. These scans essentially use a special tracer that's absorbed by these specific hormone-producing cells, making the tumor kind of light up like a chemical beacon. It really helps us find those extra-adrenal tumors or potential metastases.
Very cool technology. And linking back to that rule of tens, we talked about genetics playing a significant role. Does that come into play in the diagnostic process too?
Definitely. Given that, as we mentioned, perhaps up to 40% of cases might be familial, genetic testing is often indicated, especially in younger patients, or if there are bilateral tumors, or if there are any hints of a family history. These familial cases are associated with specific genetic syndromes. You might have heard of some like MN2A or 2B, von Hippel-Lindau syndrome, neurofibromatosis type 1, or familial paraganglioma syndromes linked to SDHX mutations. Identifying these genetic links is crucial, not just for understanding the patient's own condition and risk, but really importantly for screening their family members as well. That could be truly life-saving.
Okay, so once it's diagnosed, located, maybe even the genetic component is understood, what's the path to treatment? I've heard that the preparation before surgery is incredibly important, almost as crucial as the surgery itself. What does this intense preparation tell us about the sheer power of these hormones?
You heard right. Preoperative preparation is, without exaggeration, absolutely critical. It's probably the most vital step to prevent a life-threatening hypertensive crisis during the surgery itself. Because these tumors are pumping out so many stress hormones, the body is constantly on this dangerous high alert. So the first-line treatment, usually started about 7 to 14 days before the operation, involves something called alpha blockade. These are medications like phenoxybenzamine or doxoxydentin that work to relax and widen the blood vessels, bringing that dangerously high blood pressure down gradually and safely.
Okay, alpha blockade first. And what about beta blockers? I always hear about those for blood pressure issues.
Good question. Beta blockers, which work primarily by slowing the heart rate, are only given after effective alpha blockade has been established, usually a few days after starting the alpha blocker. It is paramount, absolutely critical that beta blockers are never given first.
Why is that?
Because if you slow the heart with a beta blocker before the blood vessels are relaxed by the alpha blocker, you risk what's called unopposed alpha stimulation. The heart rate slows, but the blood vessels can clamp down even harder, causing a severe, potentially catastrophic spike in blood pressure. It's a major risk.
Got it. Alpha first, then beta. What else is involved in prep?
Another crucial part of preparation is volume expansion. We actually encourage patients to have a high-salt diet and increase their fluid intake significantly in the days leading up to surgery. This seems counterintuitive for high blood pressure. Right. But it helps counteract the volume depletion caused by the hormones and prevents a sudden severe drop in blood pressure after the tumor, the source of the hormones, is removed.
Fascinating. So once the patient is fully prepared, their body's stress response is kind of dialed down, what does the actual treatment look like?
The primary treatment, the goal, is surgical removal of the tumor. For benign tumors located in the adrenal gland, laparoscopic adrenalectomy that's minimally invasive keyhole surgery is the gold standard. It leads to faster recovery. Open surgery, a larger incision, is usually reserved for very large tumors, or if there's suspicion of malignancy, or if it's technically challenging laparoscopically.
And after the surgery?
Postoperatively, it's important to monitor the patient closely. One specific thing is looking out for hypoglycemia, or low blood sugar. Once the tumor's constant hormone surge is gone, the body's insulin can sometimes rebound, causing sugar levels to drop unexpectedly. For malignant or recurrent disease, obviously the approach is different. Other treatments are considered, including therapies like IMIBG therapy if the tumor absorbs that tracer, or targeted drug therapies called tyrosine kinase inhibitors like sunitinib, and sometimes specific chemotherapy regimens.
Okay. What are the potential dangers if a pheochromocytoma isn't diagnosed or treated effectively? What's really at stake here?
The complications can be very severe, potentially life-threatening. The most immediate danger is that hypertensive crisis we talked about, a sudden extreme surge in blood pressure. This can directly lead to devastating events like a stroke, a heart attack, myocardial infarction, or acute pulmonary edema, which is fluid buildup in the lungs. Over time, patients can also develop a unique form of heart damage called catecholamine-induced cardiomyopathy. The constant stress hormone bombardment literally stresses out and weakens the heart muscle. Sometimes it can even look like Takotsubo or broken heart syndrome. Ultimately, if left untreated, the constant high blood pressure and systemic hormone overload can lead to multi-organ failure.
Wow. This really underscores the life-saving importance of recognizing and addressing this condition and doing it quickly. So what's the general outlook for patients once it is treated? And maybe touch again on why this condition is such a medical chameleon, mimicking other illnesses.
Yeah, the prognosis, well, for benign tumors that are successfully removed surgically, the prognosis is generally excellent. Most patients go on to live normal, healthy lives without recurrence. However, for malignant pheochromocytoma, the outlook is more guarded. The 5-year survival rate is unfortunately still only around 50%, although treatments are improving. As for why it's such a chameleon, well, its symptoms, headache, sweating, palpitations, anxiety, high blood pressure are just so varied and, frankly, common to many other conditions. It's very often confused with just essential hypertension, high blood pressure with no known cause, anxiety or panic attacks, hyperthyroidism, another rare condition called carcinoid syndrome, and even reactions to certain drugs like cocaine or amphetamines. This wide range of mimics is precisely why that thorough diagnostic process, starting with a specific biochemical test for metanephrines, is so absolutely critical. It helps cut through the confusion and avoid misdiagnosis.
Our exploration of pheochromocytoma today really reminds us that beneath seemingly common symptoms, like those headaches or palpitations we started with, there can be a really complex and rare condition silently at work. It truly highlights the incredible precision required in modern medicine, doesn't it? From biochemical tests detecting subtle hormone changes to that strategic surgical preparation that can literally mean the difference between life and crisis.
It really does. This dive into pheochromocytoma, I think, makes you really consider how intricately our body's chemistry influences our health. How just a tiny hidden imbalance, that rogue factory, can lead to such profound and widespread effects. It reminds us how often seemingly common symptoms can mask something far more complex, something requiring really careful expert investigation. What stands out to you about how the body's smallest elements, these hormones, these cells, can cause such big impacts?